It's very nice to have everyone to today's practical webinar series, and it is my pleasure to introduce today's speaker, Dr. Anna Heath. Dr. Heath is a biostatistician at the Sick Kids Hospital and an assistant professor at the University of Toronto. She's an expert in Bayesian clinical trials and innovative trial design, and also leads the statistical analysis committee of the practical platform. And today she'll be giving an introduction to Bayesian trials. And Dr. Heath, thank you so much for joining us today. The floor is all yours.
Thank you. I've taken this introduction to be really an introduction, so I don't touch too much on the kind of adaptive platform parts of the kind of title of this webinar series, but hopefully it will give a kind of introduction to some of the things that we think about when we're designing Bayesian trials. Okay, great. Oh, no. I have some funded grants from CIHR, NSERC, and the Canadian Statistical Sciences Institute, but I don't have any financial relationships to disclose. Yeah, similarly, I have no conflicts of interest. Oh, okay, perfect. And before I begin, I wanted to just do a land acknowledgement. I work at the Hospital for Sick Children or Sick Kids, and I'd like to just begin by acknowledging that the land on which Sick Kids operates. For thousands of years, it has been the traditional land of the Huron-Wendat and Petun First Nations, the Seneca, and the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island, and Sick Kids is committed to working towards new relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land in caring for children and their families. So just to give an overview of today's seminar, the main goals would be to understand the difference between Bayesian and standard, or what we call frequentist trials, to understand how to interpret a Bayesian trial analysis, and to have some understanding of how Bayesian trials are designed. So just to give a very brief kind of standard introduction to Bayesian analysis, there are three kind of key components to a Bayesian analysis. The first is a prior distribution, and as kind of suggested by the word prior, this represents beliefs about the quantity of interest before the study takes place. So before you run the trial, you have to provide some representation of your beliefs about the quantity of interest before you look at the data. So that's represented by the black dashed line on the plot. The next piece is the data. So this is obviously completely the same data that you would collect if you were doing a standard trial. And essentially, we represent it as kind of a distribution of the collected data. And essentially, you can think about this as basically the data giving its information about the plausible values of the quantity of interest. So the quantity of interest might be something like the hazard ratio or the odds ratio for a trial. It might be the risk difference. Whatever you think of, whatever you're trying to estimate in your trial is this kind of quantity of interest. And then we can represent what the data tells us about this. And that's represented in the blue dashed line. And then the key kind of component of a Bayesian analysis is the posterior distribution. And this is the final analysis, which essentially formally combines these two sources of information. And it's this combining of sources of information where Bayesian kind of gets its name from. Essentially, there's an underlying formula, theorem, which I'm not going to display today, that was initially proposed by Bayes. And essentially, it tells us mathematically how we should combine the prior distribution and the data in order to basically combine those sources of information and summarize all of the information that we have about the quantity of interest. So if you look at the plot, I have the posterior distribution there represented by the pink line. And what you can see in that plot is that actually the pink line, the posterior distribution, is pretty close to what we see in the data. So when we kind of developed our prior distribution, we actually weren't very certain about what the value of the quantity of interest was. It could be anything between 0.05 and 0.8. And so because of that, the information in the data is almost all that we have in the posterior distribution. They match each other very closely. However, the peak of the prior distribution was slightly to the left of the data, and so the posterior distribution is shifted very slightly to the left. And then the other thing to notice is that the posterior distribution is more peaked than either the prior or the data. And essentially what that represents is that by combining these two sources of information together, we have more certainty about the quantity of interest than by considering either of those two pieces of information separately from each other. So I think the crucial kind of piece to take away from this in terms of the key components of a Bayesian analysis is that compared to a standard analysis, we do need to quantify this prior distribution. But it is possible to put very limited information in your prior distribution, and that would mean that the posterior, which summarizes all of the information, would be very similar to the data that you've observed. I like to think about Bayesian as kind of not necessarily just a way to analyze data, a method to provide kind of answers from data, but actually a little bit more like a philosophy. So we kind of start in the upper right corner, and we have access to kind of the current evidence. And that might be current evidence that's pretty clearly quantifiable. For example, evidence that you have in maybe your day-to-day practice. I think in like ICU trials, you often do have quite a lot of information about the way how successful different interventions are, because you actually use a lot of interventions in day-to-day practice. So you actually maybe have quite a bit of current evidence, or it might be that this is a completely new like biologic therapy that you've never seen before and you have very little current evidence. And we call this the prior. And then we use that prior to design our research. So we both have the prior that's used in the analysis, but it also helps us think about what the research we should do is. So for example, if we have some information from a target trial emulation showing that a specific drug seems to be effective at protecting against mortality, then that might encourage us to design a clinical trial to investigate this further. Then you would kind of perform that clinical study, so your randomized trial of that drug. You can update your evidence, so you essentially incorporate both the information from the prior distribution, appropriately accounting for the fact that it is maybe not randomized evidence, and so there may be some biases. You update your evidence to give you a posterior distribution, and you can use that posterior distribution to make decisions about whether your treatment should be used in clinical practice or not. And then in theory, which I think is really where I think that the Bayesian philosophy actually really speaks to how we think about learning, and particularly, you know, improving clinical practice maybe in a more informal way. You make a decision about whether it's used in clinical practice, and then if you think that more evidence is needed, the posterior distribution that you had can essentially become the prior distribution for the next study. So we kind of have this idea that like today's posterior is tomorrow's prior distribution. So it's almost like a way of thinking formally about how to learn from evidence over time and make sure that your analyses incorporate all of the information that's available, rather than a more standard approach, which almost kind of asks you to start from scratch every time and say, okay, imagine we have no evidence against this hypothesis. How likely is it that this intervention works? And we kind of get stuck kind of assuming the same thing over and over again. So it's in some ways, it's kind of maybe similar to the idea of a meta-analysis, where you actually kind of build the studies and analyze them together over time. And meta-analyses actually often use a Bayesian approach as their analysis. So what do you actually need for Bayesian trial design? So there are actually, before I move on to Bayesian trial design, are there actually any questions on just like those kind of fundamental pieces? Okay, doesn't look like it. Okay, so in terms of trial design, I always like to put up this kind of idea as like, what do you actually need when you're doing standard trial design? Well, we need to define our research question, which is often kind of conceptualized in this population intervention comparator outcome PICO framework. You might have a T in there for timing of the intervention. But essentially, we actually need to design the research question before we think about the analytic framework. So I think you can work with your statistician to really help to formalize your kind of trial design question. But actually, at the end of the day, this is still something that doesn't require a specific Bayesian or non-Bayesian framework. You're also going to think a lot about what your secondary research questions are. And what other outcomes do you need to collect in order to give maybe a more wholesome view of the efficacy of the intervention. You need to make design decisions. So are you going to have interim analyses in your study? Are you going to think about looking at harm or safety really early on? Are you going to have multiple interventions? So you have maybe a 3-arm trial or a 4-arm trial. Like all of these things are decisions about the trial and what you want to answer and achieve that don't actually require a Bayesian or a frequentist approach. You're also going to be thinking about what sample sizes are feasible, what can you get funding for, um, what can you actually recruit, what's the um, incidence of this particular population and things like that. So there's lots of pieces that have to be thought about whatever happens. But the piece that is unique to Bayesian trial design, and I think hopefully that's obvious from the first couple of slides, is that you also need to think about your prior distributions when you're thinking about a Bayesian trial design. And those prior distributions are really going to be the only thing essentially that differs between the two types of design. So I'm going to spend a little bit of time now just thinking about how you develop a prior distribution to give you some ideas about how you might go about designing a Bayesian trial as opposed to just designing a trial. There are two main frameworks that we think about for designing prior distributions. One is an informative prior distribution, and one is a non-informative prior distribution. So perhaps unsurprisingly, an informative distribution aims to incorporate relevant external information into the trial analysis. So this will either be in the form of external data, for example, a target trial that you ran in the same patient population with the same interventions and outcomes, or potentially just observational data from the clinic, from the hospital, or it could be a previously published RCT in the same area with the same interventions that didn't give exactly the information that you were interested in. Alternatively, to external data, we can use something called expert elicitation, which is a method for quantifying expert. Sometimes people call it beliefs, but I like to think about it as like quantifying expert knowledge. Like experts who work in a specific disease area have a lot of knowledge at their kind of in their brain just from working with these patients day in, day out. And expert elicitation is a way to kind of allow them to quantify that in a scientifically rigorous way. And I will talk a bit about both of external data and expert elicitation as we go. The other way is this non-informative prior, which aims to have minimal impact on the study results. So essentially that the goal of a non-informative prior is essentially to align the pink for the posterior distribution with the dashed blue line for the data. So you're bringing no external information into the analysis. We haven't quite spoken about the Bayesian interpretation, but the Bayesian interpretation does have some strengths, and we'll talk about that when we talk about how do we kind of interpret the results of a trial. And so lots of people like to use non-informative priors in order to allow for that Bayesian interpretation without needing this prior distribution. And one of the challenges of that, or potentially not challenges, is that this means that it doesn't typically reduce the sample size requirements of your trial. So I know, and when I wear another hat as a scientist at the Hospital for Sick Children, one of the issues that we have a lot in pediatrics is that we have very small sample sizes, particularly if we start looking at rare diseases in pediatrics. And so one of the advantages that people talk about for a Bayesian trial is that it can reduce the sample size requirements for your trial and make it more feasible to actually collect the data and get an answer. But a non-informative prior would not allow that. We recently did a review of Bayesian trials, and most trials that use a Bayesian approach actually use this non-informative prior. So although the main difference between a Bayesian and a standard analysis is the use of a prior distribution, often these trials don't actually use that. And essentially what they're using is the Bayesian interpretation without bringing in external information that could potentially bias the results of the trial. So how do we think about data-driven prior distributions? Just to give you an idea if it's something that you wanted to think about. This is just an example of one of the kind of ways that we've done it. This is for a clinical trial in children aged 1 to 13 who are requiring a simple laceration repair in the pediatric emergency department. And essentially, these children, often having had the injury, they can be quite distressed, and they can be distressed. They can become even more distressed when they need to have their laceration repair, which can make it difficult to do the repair. So the intervention and comparator in this particular example were 3 different anti-anxiety medications, or they were used for anti-anxiety medications: dexametasomidine, midazolam, and nitrous oxide. And the outcome was this observational scale of behavioral distress revised, or OSBDR score, that was summed from initial positioning to the tying of the last suture. So we actually have 2 kind of ways that we use the data. On the left-hand side, what you see is a previous study that used midazolam M and nitrous oxide N during the suturing of a specific in this particular patient population. And what we saw was that we had OSBDR scores, so they collected exactly the same outcome that we were interested in. And we had suturing and a mean of 1.9 and a mean of 0.4 for this observational distress outcome. And that was what we could use as our prior distribution. So something centered on 1.9 for midazolam and 0.4 for nitrous. And then elsewhere in the paper, there was information on the variability that allowed us to formally perform the to kind of develop the prior distribution. For the dexametasomidine, we actually had access to individual patient data from a previous study, but that individual patient data actually collected a different score. So although the outcome in the study that we were designing was this observational scale of behavioral distress, or OSBDR score, the score in the data that we had was this pediatric state sedation scale, or PSSS. But so what we found in the literature was that there was information on the right-hand side there about the relationship between the PSSS scores and the OSBDR scores. So we were able to use those relationships plus the information that we had from the previous study to create a prior distribution for dexmedetomidine. In this case, the number of patients in the dexmedetomidine trial that we had was much smaller than the number in the previous published study for midazolam and nitrous. So the prior distribution for dexmedetomidine has much more variability than the one for midazolam and nitrous. And that also accounts for the fact that we had the wrong outcome and we had to do this translation. So you can see how you could use both individual data, but then appropriately account for differences, or you can use published literature to do your data-driven prior distributions. Alternatively, you can use what I said, this expert elicitation. So in this case, this is an example of how we performed an expert elicitation. And in this case, the study was in infants aged 60 days to 1 year with bronchiolitis who arrive at the emergency department requiring care. The intervention was nebulized epinephrine and a 2-day course of oral dexamethasone or Epidex, and the comparator was placebo, and the outcome was hospitalization within 7 days of study enrollment in the emergency department. So essentially what we have here is a kind of an online tool that clinical experts can use to provide their experience of treating patients in the emergency department. So it starts at the top with a question, which is a clinical case describing a patient with bronchiolitis. And then the question is, out of 100 similar patients with bronchiolitis, how many would end up being admitted to hospital either at this ED visit or up to 7 days following this visit if you treat with supportive care only? And what's nice about this is that supportive care is the standard of care in Canada. So actually these it's a very high volume patient. So there actually is a lot of expertise. And then we ask the experts to kind of choose the lower and upper plausible values for the number of patients admitted with bronchiolitis, and then also select their best or most likely value. And this allowed us to create prior distributions from expert experience. So those are the two main ways that you can get prior distributions if you want to incorporate information into your study. If you want to use a non-informative prior distribution, then there are kind of statistical rules of thumb that you can use, and you can work with your statistician to incorporate that into the study. Okay. So to give you kind of, that's thinking about how we design, now moving a little bit forward into how to interpret or how to kind of work with the results of a Bayesian analysis. So the really nice thing about a Bayesian analysis is that the posterior distribution, which is the distribution that summarizes the data, the information from the prior and the data together, essentially, by definition, contains all of the information about the treatment effect. So if you have this posterior distribution, you have essentially fully characterized your beliefs, or the beliefs, the information that's available about the treatment effect. And what we then need to do to be able to kind of make decisions and also to report is we essentially need to summarize that posterior distribution into something that's maybe more easy to interpret. So while you can produce the graphics that I have on the right-hand side and just give that information, that provides a complete summary of the information available about the treatment effect, it's more common to summarize the posterior. For example, you can compute the mean of the posterior distribution. So in this case, it's 1.7. So we have a posterior distribution for the odds ratio. The mean posterior is essentially kind of the average or the expected odds ratio. So that might be equivalent to the estimate of the parameter that you would get in a standard frequentist analysis. That would be 1.7. You can also compute the median. That sort of gives you an idea of the middle, the most likely or the middle value, which in this case, because we have an odds ratio, the distribution is slightly skewed. You might get a 1.6. You can report the variance of the posterior distribution, in this case 0.19. That would be equivalent to a standard error or standard error squared that you would get in a standard analysis. So this gives you like an understanding of the variability or the uncertainty in your treatment effect estimate. You can compute what we call credible intervals, which basically a 95% credible interval, which you can also see is marked on the graphic here. It actually gives you the interpretation that I think everybody wants to say for a confidence interval in a standard analysis. Essentially, there's a 95% chance that the the parameter value lies between these two values. So essentially, what you're seeing here is that there's a pretty wide range of values that are possible for the odds ratio, and yet there's a 95% chance that the odds ratio is between 0.94 and 2.56. So that's what I was talking about earlier in terms of Bayesian interpretation. It actually allows you to make that statement that there's a 95% chance that it's between these two values. The other piece that you can compute in a Bayesian analysis that isn't available to you in a standard analysis is the probability that the treatment works, or the probability that the odds ratio is greater than 1. And in this case, we have a 98% probability that the treatment is effective. So that's this grayed out area here. And to my slightly biased view, because I think that Bayesian makes a lot of sense, this is actually the result that allows you kind of the greatest benefit of performing a Bayesian analysis, is that it actually allows you to compute the probability of a meaningful effect. And that can help you think about decision making going forward, particularly as it doesn't necessarily imply a cutoff like you would have in a standard analysis, like, oh, we need it to be less than 5%. It can actually allow you to perform trade-offs yourself. So if, for example, you had an intervention that was less intensive than another intervention, you might allow yourself to have a smaller probability of a positive treatment effect to be the threshold at which you're like, you know what, I want to use this treatment because it's less intensive, and there's a pretty high chance that it works. Alternatively, you might have something that's much more invasive, and at that point you might be saying, okay, well, because of the issues that I have with this intervention in general, I need it to be like 99.5% value of it being effective, probability of it being effective. Alternatively, you can also compute the probability of like a meaningful effect. So you can, instead of just doing the probability that the odds ratio is greater than 1, you could say, okay, well, clinically it's not relevant to switch this intervention unless the odds ratio is above 1.2. So what's the probability of being greater than 1.2? And so you can actually adjust these ways of presenting the results to provide summaries that are meaningful in your clinical area. Okay. I just had a little piece about kind of adaptive clinical trials. I know we have this adaptive platform thing. And the FDA defines an adaptive clinical trial as a clinical trial design that allows for prospectively planned modifications to one or more aspects of the design based on accumulating data from the trial. So the critical thing about an adaptive design is that you have to, in the design phase of your study, you have to decide how you're going to adjust your trial conduct. So it's not kind of adaptive on the fly. It's really adaptive in a protocolized way. You say how you're going to adapt and why that's important. But crucially, an adaptive design is also something that adapts based on the data from the subjects in the trial. So a trial that adapts its conduct based on alternative publications that come from a different study team, or kind of evolving changes to the standard of care, those that come from external to the trial, those wouldn't necessarily be an adaptive design, although the clinical trial itself does adapt. There are different types of adaptive trials that you can do, Bayesian or non-Bayesian. The most common type of adaptive trial actually is a dose escalation or a dose finding trial, where you're trying to like identify the optimal dose to go forward. And those are always reactive. So you would give like the intervention to 3 patients and then see what happens, and then either escalate or stay the same depending on the toxicities and things like that. The simplest, I think, type of adaptive trial, which maybe is something we should advocate for a little bit more, is this idea of sample size re-estimation during the study. So for example, sample size is often very heavily dependent on the assumptions that you make about variability in the outcome, or baseline risk if you're using like a mortality outcome. And if you have drastically different baseline risks in the trial than you do in your assumptions, that might mean that your sample size is inappropriate. And so you can make changes to that over time. And that actually, I think, is also one of the advantages of other types of adaptive trial, where you look at the data as you're going through the trial, because it also allows you, if, for example, you have less variability than you're expecting, you might be able to stop earlier. You can add or remove interventions from a trial. Removing is kind of easier to pre-plan for than adding. Adding often requires external information. For example, oh, this novel technology has just been approved in Canada, and we would then like to add it into our trial. You can stop the trial for efficacy. So you see that one of the interventions is clearly superior, we're going to stop. Or alternatively, for futility, where you kind of don't see any potential to reach a conclusion. You can change patient allocation. So maybe you want to prevent certain patients from being allocated to a specific intervention, or you want to up weight or randomize more and more people to more effective interventions. You can focus on patients with higher potential to benefit from interventions. So this is particularly important, I think, in the context of ICU trials where you maybe have a lot of heterogeneity. You might want to focus on patients who are maybe higher acuity because they seem to be the ones that are getting the greatest benefit from the intervention. You can address multiple trial aims at the same time. So really thinking about maybe dose finding and efficacy analyses at the same time, or you can combine adaptations. Let's see, yeah. The Bayesian approach actually is an easier approach for adaptive trials. And the main reason for that is because this react and review stage in the adaptive trial, where you react to the data that you've collected, in a standard analysis, you actually need to adjust your analysis for the fact that you looked at the interim data, whereas a Bayesian analysis doesn't require that. So you actually get the same interpretation, irrespective of whether you looked at the data during the trial or you just did it all in one batch. And that's essentially due to this kind of Bayesian philosophy circle that we talked about initially. Today's posterior becomes tomorrow's prior, and it doesn't matter whether you do that in steps or whether you do that all in one go, you still end up at the same posterior distribution. So how do we make decisions in Bayesian adaptive trials? The most common approach is to use the probability of a positive treatment effect, or something that kind of summarizes the probability of something. So sometimes we look for the probability of a positive treatment effect. Sometimes we might look for the probability of a futile treatment effect, a treatment effect that's too small to detect, or something like that. We might look at the probability that these two interventions are equivalent. But essentially, we summarize the posterior distribution directly by computing the probability of something to do with that odds ratio. And typically, we would then have a threshold. For example, you might stop for efficacy if the probability of a positive treatment effect is greater than 99%. That would allow you to kind of say, okay, we're pretty confident that this treatment works, we're going to stop recruitment. Alternatively, you could have a threshold saying if the probability of the positive treatment effect falls below 5%, we're going to stop this intervention for futility because we don't think that there's any evidence of efficacy. So you can do the same thing there. The other kind of decision-making criterion you can do, which is has been used quite frequently, is what we call a predictive probability of a positive result. This is a fairly uniquely Bayesian way of thinking, but essentially what you do is at the beginning of the trial, this is the observed data that we collect. So we have half of the trial data collected at this point. And then what we're going to do is we're going to use the posterior distribution, which gives us beliefs about what the treatment effect might be, and an understanding of how the data progresses. And we're actually going to predict what the data might look like over the rest of the trial. So these these dashed lines represent potential future trials, or a potential future in which we continue the trial and we get evidence, we get this particular data collected. And what you can compute then is the predictive probability of a positive result of the trial. So this is quite often used if you're doing maybe a phase 2 study, and you can compute the predictive probability of a positive result at phase 3. So for example, if your phase 3 study needs to recruit 3,000 patients, you would say, based on the phase 2 data, what's the probability that I get a positive result with 3,000 patients? And you can use that to say whether you should continue to phase 3 or not. For example, if you have a probability of 80%, you might say that that's sufficient to move forward to phase 3. But if that probability is only 10%, then we should stop the trial now. So I think this can be quite a nice way of thinking about trials when you actually have an idea of what the next study would be. So how do we actually do Bayesian trial design, or particularly trial design for adaptive trials? Often we need to use simulations. So simulations essentially mimic the data that would be collected in a trial and then analyze it using the methods that we specified. And then that helps us determine which adaptations should be made, the impact of these adaptations, and what decision rules are appropriate. So I talked on the previous slide about, oh, if it's 80% probability of phase 3, then we'll go forward to phase 3. But actually, we need to basically determine whether that 80% is the right threshold. Maybe we need 90, maybe 75. So that's what simulations allow you to do. So as a kind of a clinical team who was looking to do Bayesian trials in general, and particularly Bayesian adaptive trials, you would be looking to work with a statistical team or do it yourself. I have some clinical colleagues that like to run the simulations themselves to kind of work through what would be the impact of using that type of trial design. And simulations are generally designed through the following steps. The first is to specify the research question and the goal of the adaptive design. So obviously working through the PICO is really important, but also what are you hoping to achieve by using an adaptive trial or a Bayesian trial? For example, in a pediatric rare disease context, the goal of a Bayesian analysis would be to incorporate external information because we only have, 200 patients in the world who would be eligible for this study. Alternatively, in practical, for example, the goal of our adaptive design is usually to identify whether the intervention is effective as quickly as possible so that we can move forward and implement it in clinical practice, or if it's not effective, actually reprioritize different studies within the practical platform in order to be able to complete as many studies as possible. The next piece would be to develop a model for data analysis. So how are we going to analyze the data during the trial? What is an appropriate distribution? And then we also need to develop a model for simulation. So what are reasonable assumptions about, say, the level of mortality in the study? We need to design the trial decision rules. So those are the rules that are going to tell us how we adapt or how we conclude at the end of our study. And those should really align with the goal of the adaptive design. Then we determine the key scenarios for simulation. So all of these three questions or kind of points here are really where you need to be having a conversation between the statistical team and the clinical team about what you need, what you want, what data is appropriate, and what makes sense for your context. We would then run the simulation. So this would be more on the statistical side. And then eventually, once we have those, the key thing will be to evaluate the results and present to key stakeholders. And in some cases, that presentation can sort of allow us to iterate between, say, designing the decision rules, running the simulation, presenting and discussing, and then co-creating the design together. So I had a little example from practical. So for those who, many of you I think are familiar with this, but the population here is patients with acute hypoxemic respiratory failure. The intervention is the novel ventilation strategy and the comparator is the standard of care. And the outcome is ventilator-free days. So on the right-hand side here, this graphic demonstrates the distribution of ventilator-free days. So there's about just over 35% mortality. These patients are assigned a -1. And then it's 28 minus the number of days spent on the ventilator. That give you all of the other categories. So in terms of just reflecting on we have the research question and we have kind of a model for analysis. We know what the outcome looks like in the current patient population. We have 3 adaptations that we're interested in. Futility, so that's basically trying to, if it looks like an intervention isn't likely to be effective, we want to take it out of the trial as quickly as possible in order to allow us to orientate towards more important questions. We want efficacy, we want to adapt for efficacy. So if it looks like the intervention works, we want to know that as quickly as possible and stop, and then start to implement that the novel ventilation strategy in clinical practice. And then the other piece that we were interested in is treatment effect heterogeneity. So we think that there's a chance that there are differences in efficacy based on different criteria in the study or different severities. So here we have 2 severity states. So we're going to look at heterogeneity by these 2 severity states. So those were the 3 kind of key adaptations that we were interested in this trial. And what do we do when we do our simulations? Well, we're looking at kind of trying to optimize or make the design as kind of perfect as possible. So here on the left-hand side, what we have is a representation of our decision rules. So the blue box here is what we defined as superiority. So a treatment effect greater than 1 is defined as a superior treatment effect. And then we had futility, and we said that a treatment effect less than 1.2 is a futile treatment effect. So what we're doing as we recruit patients is this basically represents the posterior distribution mean and credible intervals. So you can see that as we collect patients, the mean changes, but also the credible intervals become narrower. So you're getting to see that kind of evolution over time. And then what we're computing is the probability of superiority and the probability of futility at each interim. And then we'll stop the trial when the probability of futility is greater than 0.9, or the probability of superiority is greater than 0.99. So what you can see here is this is a 95% credible interval. So because we're very close to the futility, this meant that the probability of futility fell below 90. So we stopped for futility here. Although there is the mean treatment effect is still in this superior region, we would basically find it very, very difficult. If this was the true treatment effect, it would be almost impossible to declare superiority because you're going to need to get a credible interval that's kind of the size of this gap here. And as you can see, we're already at close to 1,800 patients at this point. So this would be one simulation that we run. And then what we actually do is we run many, many simulations and many, many different trial designs to determine the optimal trial design. So just to give you a little bit of an idea, here, the key things that we changed were the initial recruitment, the superiority probability, so the threshold for stopping for superiority, and the threshold for stopping for futility. As the dots get bigger, the initial recruitment gets bigger. And then on the graphic, we have the expected sample size of the trial. So this is how many patients we think we would need to recruit in order to stop for either futility or superiority. And then we have the power of the trial. So the probability that we declare superiority at an odds ratio of 1.3. And so what you can see is what you see normally, that the power increases as the sample size increases. And these two plots represent our heterogeneity. So this is for one severity state, this is for the other severity state. Generally, as I said, the sample size increases, the power increases. But what you can see is that that's not always universal. There are some points here where you can get very similar power for less sample size. So this is really the design that we're looking for. We want to find ones that are kind of on this edge here. These are the best designs that we can choose for our study. And interestingly, they're the same design across both plots. So you can see that this kind of small blue square, for example, would be a good design because it falls right on the left-hand side on both. And while this triangle here, for example, is great on this, it actually maybe is not so great on this plot. So that might be a design that you wouldn't want to do. So looking at this plot, thinking through the feasibility of the recruitment numbers. So for example, how feasible is it to recruit 900 patients, or do we actually need to go for this, which would be closer to 700, just because we need the sample size, although that would be at the expense of power. So that's where we would start to have a conversation between the statistical team and the clinical team. So in general, I've kind of had a summary of kind of the advantages and disadvantages of Bayesian trials, and then also remembering that Bayesian trials can make it easier to do an adaptive trial. There are some kind of elements there. So the advantages of a Bayesian trial: you can formally incorporate external information to reduce the required sample size of your trial. That's particularly important if you have something that's very rare, where actually a standard trial is just completely infeasible. This is a way to get some information to make better decisions. It can provide the probability of a meaningful treatment benefit, which I would argue is a more interpretable way of thinking about the results of a trial. It gives you more natural interpretation of uncertainty intervals. So you can say, oh, the probability that there's a 95% probability that it's within these intervals. They can be simpler. Bayesian methods can actually be simpler to implement for complex outcomes and complex models. So if you have like data collected over time and you need like a longitudinal model with shared effects across the same patient, they're actually much easier to implement in a Bayesian framework. They don't tend to have the same computational challenges. Priors, in addition to bringing in external information, can be used to what we call support regularization, which basically means that it can make the model better behaved, so you can use more complicated models. And that it's much easier to interpret adaptive designs if they're analyzed in a Bayesian context. The disadvantages, available software can be complex and poorly documented. There's a lack of familiarity, which hopefully some seminars like this will help with, but that can lead to issues with acceptance. The prior distribution that you choose has to be defended, and sometimes people might just not accept that that's a realistic prior distribution, and you have to do kind of sensitivity analysis to your prior. Adaptive trials are operationally more complex, and they require a more intense statistical design process, which is great for people like me who love designing complex trials, but can be more expensive, and they can delay you submitting for funding. And the other thing is that because they're more complex, they kind of can open themselves up to more like critique in the review process or something like that. And adaptive trials generally are less suitable for long-term outcomes. So if you're looking at like 5-year survival, it might be difficult to do an adaptive trial because you actually don't have the available information, and you might actually recruit all the patients before you have all the information to make your adaptations. That I think actually is a critique that's less relevant in critical care trials, at least as far as I've seen, but just something to keep in mind if you do start working in trials, maybe in like more in the rehab space, where you are looking at much longer term outcomes. So yep, that is everything I had to say today. I will stop sharing and open for any questions.
Amazing. Thank you so much, Dr. Heath, for the amazing talk. If anyone has any questions, please feel free to say that in the chat or opening your mic and just asking the question.
Yes, that was a great talk. Thank you. I have a question. How do you deal with heterogeneity of patient populations, enrollment criteria, methods and studies in making up a prior distribution?
Yeah, it's a great question. So I think there's a clinical kind of way that needs to be done. I think there needs to be a really important assessment of how relevant the published data is to the trial population of interest. And for the most part, that is not a statistical question. That's a clinical relevance question. And so I think there needs to be a discussion about how to make a decision about what's the relevant information to start with. That being said, statisticians love a problem. So there are also statistical kind of techniques that we can use to kind of measure the similarity between two kind of data sources, and then essentially that kind of downweights the information that you have from the external or the previous data if it conflicts with the data that you collect in the trial. And there are lots of different ways that people have thought about doing that. The other piece that you can do is you can just create what we actually call as like a down weight. So what you would say is like, okay, maybe I have 100 patients in a previous study, but I know that there's huge heterogeneity compared to the population. So instead of making the prior worth 100 patients, because we had 100 patients previously, we'll just make it be worth 5, because that basically accounts for the fact that we think these patients are not as similar as they could be to the patients in our trial. And some of that, again, is a judgment call about whether it's them being worth 5 or 20 would be to do with how similar the populations are. And again, that might be something you have to discuss, kind of how to turn your clinical judgment or intuition into a quantifiable number. And so there are ways to do that as well.
Thank you.
I think Vittorio Scaravilli. Sorry, Vittorio, I think you're muted.
Sorry. Yeah, sorry. Thank you, Anna, for your talk. I just have a question. How do you manage when you have conflicting priors? So when a study is telling one thing, the other one is going on the other side, and you want to, how do you work that out?
Yeah, it speaks a little bit. There's a question in the chat that just says, how does a Bayesian meta-analysis differ from a Bayesian analysis that uses priors based on data alone? And I think they actually kind of get at the same problem. So if you have significant heterogeneity in the literature, you can use essentially methods from like meta-analysis that basically say, okay, well, I'm going to account for heterogeneity that says that these two studies are different from each other. And then that is going to give me a prior that kind of says, not only that I think this third study is also potentially going to be different. So I'm going to give myself more, like, basically I'm going to have more variability in my prior distribution. And so that's one way to do it. The other way would be to really think carefully about what is a relevant study. I often find that there might be like two really different studies. Either it's because they're both really small, and so actually like combining them and being like, well, we don't really know either way is actually appropriate because that represents your beliefs. Or alternatively, the closer you look at it, the more like, this happens quite a lot because I do lots of pediatrics. Like would be like, oh, there's these two studies. Oh, but one's in adults. And then we just go with the pediatric data. So maybe it's not that. But from the Bayesian meta-analysis to analysis that uses priors based on the data alone, theoretically, if you use the same models, you should get the same answer. But what usually happens is that a meta-analysis has more accounting for the heterogeneity. So you're using these models that say, I'm going to account for the fact that there are differences between these trials. Whereas if you just put all the data in, you might not account for that heterogeneity in the same way. And that would give you a different response.
Thank you very much. Thank you.
Okay, great. Maybe we'll have time for just a few more questions. I have one question, Dr. Heath. I think one of the worries in making decisions on interim analysis are like random highs or lows, right? Do you think the Bayesian framework protects against that, or should more skeptical priors be used in the interim analysis when compared to the final analysis, or this is not a problem in the Bayesian framework?
So it's certainly, I mean, anything can be a problem. Like, yeah, if you analyze like 20 patients or something, there's a chance that you have a random high. 100% there are Bayesian like ways to deal with that. As you say, you can put a skeptical prior and you can weaken that skeptical prior as you go so that you make sure that you don't like get these really big fluctuations. The other thing you can do is you can set pretty stringent requirements for your decision making. So like a 99% probability of effectiveness is, to me, is like a very high bar to get over. And that what that's saying is that like if you think about what I was talking about, predictive probability, that's another thing you could use. Is you could say, okay, well, what's the predictive probability that this intervention doesn't work if we look at another 3,000 patients? And that might be a way to guard against that, or at least to think about how to guard against that. But to be honest, the way that I actually usually guard against it is I actually just ask, like, clinically, how many patients do you need to see to be convinced? because there's no point in stopping a trial at a point where you're not able to change practice. So I think that you do also need to have a pragmatic kind of lens and be like, if we know that the standard like size of trials in this population is 300 patients, we probably shouldn't try to adapt before we get that, because otherwise we're just never going to be able to get the impact that we want.
Okay, thank you so much. All right, so thank you so much for the great talk and for the discussion. And see you everyone in the next practical webinar series session.
Thank you.